Well, good evening, Western Australia, and to those on the eastern seaboard who may be staying up a little bit later, and also to any New Zealand healthcare providers who simply just can't get to sleep at this time of night. Welcome to this fourth session, the final session of our webinar series titled Polio Survivors and Their Health Conditions. This last session is information for allied health practitioners, but really we're just taking more of a look at the functional aspects of polio survivors as opposed to the medical, and the previous look at conditions, and then the profile of polio survivors really started back in session 1. The previous 3 webinars provided quite a lot of information. Obviously, elements of those sessions will be referred to today. The aspect of the reflection form that I've been pointing out that I want to highlight tonight is the screenshot question. Technology of being able to watch webinars on digital devices, to be able to easily take a screenshot of something that would otherwise flash us by in a live presentation. We can always look back, and it's a learning tool that we can use to bounce back to something that we wanted to go over in detail, or to think about something we had heard. But that's one of the beauties of the webinar format. We can take notes, but we can also take snapshots of what we see visually. And so you may have taken some snapshots, so it's worth looking back at those for this one main reason, and that reason being asking which of those snapshots can now be deleted because you have internalized the point or the concept, or you've moved through the webinar series, and those original screenshots from session 1, you're kind of like, okay, I get that now. I don't need to have that stored on my device. Think about that in terms of the reflection aspect, even including the time beyond this particular session. This session in particular is being aimed at healthcare practitioners, serving to bring awareness to the barriers to overcome and avoiding the status quo when dealing with polio survivors, and understand those comments as we move through, particularly the status quo one. The first one I point out are reality. Polio survivors will judge your capability based on their risk of worsening. So it's a fairly strong motivation, understandably, for someone who has post-polio syndrome, and even for those who have late effects of polio. Recalling that the phone questions and email questions we often get from survivors is, how much am I going to lose? At what rate? When is this going to start happening? And those questions we can't answer. And so it would be considered quite normal for them to have a level of anxiety based on that condition. So survivors will be less driven by things like how fast they will improve, or how great they're going to get in terms of function. They certainly have a good sense of reality when it comes to their abilities and functions. So we're going to start with looking at barriers, and we're going to actually see a few of these quotes that I'd read from last night's session here. Barriers can certainly be overcome. It's not that something that is a dead end in terms of treating a polio survivor. It's just things that they have identified from our survey earlier this year that really highlights that they sense these barriers when they're trying to obtain their health care. So I color-coded them to make it a little easier to pick out the themes. And if we start with green, we can see the top left one is one of the quotes from last night. Because I appear very healthy, they often cannot see why sometimes I get so weary. So green is about making assumptions, how that can be a barrier to someone receiving care. They assume deformity due to birth or accident, and if you were to do that, polio survivor, you'd be considerably undercutting potential for improvement and hitting the nail on the head in terms of treatments that are most likely to have an impact. Now, of course, some polio survivors have been in accidents and may have had a birth defect as well, but if they do state that they've had polio, roll with that. In the blue, these two comments reflect lack of time or interest for the tools necessary to treat the patient. So getting them to read my file and not conclude that I'm just old. And they know of the condition but seem to skip over the problem. And reading some of these, you can feel a little bit unsettled about a patient making these comments, but they've been honest in their assessment of the experiences that they had. In the red, we have, they think that my weaknesses can be rehabilitated or strengthened. They don't always listen. You tell them that you do 3 exercises, and then they say to do 10, and then being unfamiliar with potential impacts of some treatments. So those ones in red reflect a limited base knowledge of the conditions that polio survivors have. In orange, we have assessment errors, inability to accept a problem exists, or maybe even an inability to recognize the problem for what it is. But it's worth having a good look at this one in the orange, because this really reflects on a clinical error that seems fairly straightforward, but we have to think about how we're trained as healthcare practitioners in allied health. It's always useful to have indicators and benchmarks and signposts for making your problem solving and clinical reasoning easier and more effective in most cases. But remember, this is not the status quo. And this quote really highlights that. When I have had an injury, i.e. a blood clot in my bad leg, the atrophied side, which caused it to swell to become almost the same size as my good leg, it was difficult for them to understand how swollen it really was, because they are trained to compare limbs as being the same size. So quite an impactful and very insightful comment by the polio survivor. So if we attend to these barriers, these assumptions, the lack of time or interest or tools, the knowledge base, the assessment errors, those are all practitioner side things, but we have to appreciate there are also internal barriers on the side of survivors in terms of obtaining the healthcare that they need. One of those was actually saying the words that internally, motorically, polio damaged nerves controlling their speech. We also have other internal barriers like trust of healthcare professionals, which can stem from traumatic experiences receiving healthcare in their childhood around the time of their polio, particularly with relation to surgeries, anxiety about their level of decline or the range of symptoms or the severity of symptoms and what it's going to do to their function, and having a resistance to change in terms of ways they've been performing things for decades, perhaps, that have been very successful and have allowed them to be independent, to shift away from that pattern or that usual action can be quite difficult, and there can be some resistance. We're going to delve into that a little bit later in this session as well. A survey of Western Australian polio survivors from about 7 years ago. We got some really great information out of this. And you may recall this particular slide from session 2. And we'd use that to discuss, after we had a lot of discussion on symptoms of these polio conditions, I pointed out that Symptoms are one thing, but impact on function is another. So we're going to spend quite some time during this particular session discussing that context of the late effects of polio. So for the remainder of this session, consider for your particular allied health discipline how you can address the symptoms polio survivors report to stabilize the functions of the patient. If we take a look at this list, it presents as very weakness-oriented. And in session 1, at the very start, I had mentioned that one of those conceptions or the perceptions of polio survivors is that they were paralyzed, they have paralysis issues and mobility issues. But we know that is not the case. What we've covered in the material so far, we certainly need to consider the other big factors of fatigue, pain, and instability, loss of balance, and difficulty with controlling balance. How those particular symptoms may play into these factors that we have on the screen now. It can be easy to status quo style, just say, these are all weakness issues. Send them to a physio, strengthen them, and that should improve things, and go from there. Now, that may well be a place to start, but let's look at an example in more detail. So let's take dropping held items as the example. Even though that may not have ranked highly as our other ones on this grid, the percentage doesn't really matter. Can we have weakness causing dropped held items? Indeed, we may have someone who is holding something that is at a threshold load or weight, and as they develop these symptoms, it may breach that threshold. They may be able to unable to hold something of a particular weight, or size, or shape, or dynamic weight kind of thing. So grip weakness may be something that needs to be addressed. It can come down to, though, do they have to carry or use a particular load or device a particular distance or time duration, and that eventually the continual use of that particular load causes fatigue and an inability to hold it, and they end up dropping it. This can be something like walking the length of a house, having to hold on to something quite heavy to transport it through a house. This can be your construction worker who has weakness in an arm and uses a drill all day, and who finds that no problems holding and manipulating his power drill in the morning, but towards the afternoon it becomes very difficult to hold. So it could be a fatigue issue. Is there osteoarthritis in that wrist of the hand they're using to hold something that's quite heavy, and that when they reach a certain grip intensity or load, that they get shooting osteoarthritic pains through the wrist? And that could be from decades of using the upper extremities as load bearing, having used crutches for a long time. Or is it potentially they've dropped an item because in their mobility they had taken a little trip or a stumble, and their reach reactions caused them to drop the item they're holding in order to have that reflex, stabilization reflex and protective reflex of the arms being outstretched. Of course, if you think about that example, the most pertinent thing would be to address falling and the instability there, but we can see that dropping a held item may easily fit into that scenario. So we really have to delve into and not make assumptions, delve into what is actually leading to this change in function from the side of the polio survivor. So we need to keep a broad view of each of the symptoms' influence on function, but these are the three main. The fourth one is going to be falls. Fatigue, weakness, pain, and falls we're going to look at over the next few slides. And we can see we've broken these down into the major types of the complaint we normally hear. One is that central fatigue, peripheral fatigue, weakness related to mobility and peripheral musculature, posture, ventilation weakness, and then speech and swallow voice, communication weakness. And then with pain, we're looking at post-polio pain, biomechanical pain, and overuse pain. It's worth looking at this picture on the right. We have an archive of pictures from the polio epidemics in Australia. This one must have been published in a newspaper or something because it has a caption, which is quite interesting to read. And you can see in the picture, the young girl, I think, is quite happy and with her nurse, it looks like. But the caption says in the first half of it says, "Faith has a big smile for the camera in spite of her disability." And that caption really shows the polarity and perspective between the society at the time and its attitudes towards disability and the child survivor and what they move through from that point of rehabilitation into their adult years. We can not assume that because somebody has a disability that they are unhappy or depressed because of the disability. There are certainly many people who have significantly meaningful lives and contribute immensely to their communities despite having a disability. It doesn't mean that they're only smiling when they see a camera, as seems to be implied by this caption. My, haven't things changed? So let's have a little look at fatigue in the polio survivor. I'm going to read out of our Managing Muscles and Mobility book because it summarizes it quite well. Late effects of polio fatigue is often associated with onset later in the day and with increasing severity towards the evening. It is important on assessment to exclude any other causes of fatigue, such as anemia or cancer. Current understanding suggests the etiology of fatigue lies in the overuse or overwork of polio-damaged nerves and muscles. Can be categorized in two forms: general fatigue, which is that central, that overwhelming exhaustion with flu-like aching, and then muscle fatigue, which is a peripheral fatigue, which is more related to strength upon exertion. So looking at this particular graphic, this is from an article that was published last year actually, called Post-Polio Syndrome, More Than Just a Lower Motor Neuron Disease. And the article does a good job of painting an overview of the symptoms and the condition, and takes that emphasis, as the title suggests, off of the motoric aspects and the paralysis aspects, and highlights a lot of these other symptoms that create interference with visual function. I believe that's freely available on the internet, and it's actually a fairly short article, so a good place to go next with your learning. It's worth noting that one of these bubbles on the side around fatigue could be the main driver of fatigue for a polio survivor. Or it could be many of these factors having a small part, but resulting in quite significant fatigue. It could be any mix of combinations. In your particular allied health discipline, it's best to think, what angle can I address this fatigue from in my scope of practice? And then beyond that, where else should I refer them or recommend they go? You may have a different perspective on managing other aspects of fatigue shown here. Also worth noting that fatigue has no correlation with age. This was found in a study, meaning that just because these survivors are older doesn't mean they get more fatigued as they age. Young survivors can be quite fatigued with quite severe symptoms, and older polio survivors don't necessarily have more fatigue than they used to have. The other non-correlating factor is self-reported impairment. So a polio survivor may have had quite significant self-reported impairments, and they may or may not have had significant fatigue. Just as a polio survivor may have reported very limited impairments, but could have reported quite severe fatigue. So there's no correlation with fatigue in their presentation when it comes to age or level of impairment. Another interesting figure here is that 77% of polio survivors with post-polio syndrome have moderate to severe fatigue when ranked on the fatigue severity scale. So fatigue is a very big deal for this patient population and certainly should be investigated dealing with polio survivors. So muscle weakness, let's look at that. How weak do our survivors get and what is the impact? Well, increasing muscle weakness can have a significant effect on the ability of a person to continue to have a satisfactory quality of life. Difficulties experienced due to weakness can be the inability to autonomously complete their ADLs, reduced balance resulting in higher number of falls, overuse of weakened and compensatory muscle groups can lead to muscle pain, affecting their function. Asymmetric atrophy or weakness can lead to contractures, pain, tension, and a greater risk of falls. And decreased muscle endurance, increased muscle fatigue, and limit them in their activities. So what does weakness look like when we're dealing with our usual tool of muscle charting, muscle grading, or manual muscle testing? This diagram, or the figures on the left, help kind of paint this picture. But we do need to keep in mind that a grade of 3 is not halfway, nor is it 50% strength, nor is it 50% of capacity for strength that a person has. If we look at this and we say, look, a lot of polio survivors have a muscle group or several muscle groups that may be in the 3+ to the 4 range, which means they have about 10 to 40% of their functioning muscle fibers are contributing to a contraction or a movement. If you think back to the Viking boat example with all the rowers, there were 100 rowers on that Viking boat. These polio survivors can be quite functional with 10 to 40 rowers driving that boat. Serial efforts are needed to screen for giant motor units. If we just test a survivor once, they can go into full recruitment of all those giant motor units and they can certainly present as a 5. But if you test them again, and maybe 3 or 4 times, within a relatively short period of time, you may see a drop-off in the grading of their muscle group. So we need to detect if there is a fade effect. And we certainly should expect some muscle groups to be 5s and to be quite resilient. That dominant or unaffected, no, unaffected is not the correct word because there's usually some underlying loss of motor units, even on the good, strong side, but we do call it the good side, not the unaffected side. So when you think back to that initial first and second session, we also talked about the loss or decline with late effects of polio, and how that was 2%. So if you look at these numbers, if someone is in that 3 to 4 muscle strength range and you start taking off 2% of their strength, you can see that that can quickly add up to drop them down a grade in a number of years over the course of a decade. So keep that in mind. Now, is there any evidence to link central fatigue and weakness? The answer is yes. A study was done that showed that there are central mechanisms activated in the central nervous system that help to increase the drive in peripheral motor units, or the amplitude. So we have this central mechanism adding a bit more juice to contractions. What that means is that essentially there's going to be a lot more strain, and hence fatigue factors may creep in there. A weakness is obviously related to exercise, and exercise is best prescribed by someone who knows how to prescribe exercise. So certainly physios and exercise physiologists fit that profile. You need to remember that it's going to be individualized because polio survivors present as very asymmetric and unique in their specific presentation. We need to look at improving to the level that was lost. So if somebody has had a surgery or a health event and they've lost a grade or two, we need to work up to where they were, saying or thinking that we can get them back to a 5 when that muscle group hasn't operated anything above a 4 for decades is certainly optimistic, but it's not realistic. And your polio survivor is well aware of that, that scenario. The other item about exercise is that exercise is medicine. It's not just about getting something stronger. It's about moving and maintaining joint integrity and reducing fractures and keeping the other systems of the body influenced by increased metabolism and blood flow and all those wonderful things that come from performing exercise. Polio survivors certainly seek those things as well and see exercise as a way to maintain their health. So the best we can do for them is to provide them with an exercise program that fits them very well and can be modified as needed over time. So pain, we have those 3 categories of biomechanical pain, overuse pain, and then post-polio muscle pain. And so with pain and post-polio muscle pain in particular, post-polio muscle pain is described as a burning, cramping, or a deep muscle ache. And deep pain is often characterized by muscle cramps, while the superficial pain is sometimes associated with fasciculation, crawling sensation, or extreme sensitivity to touch. And many late effects of polio, clients express deep frustration that this unbearable pain is not understood by others, including health practitioners. And post-polio muscle pain is usually associated with physical activity, typically occurring at the end of the day or at night. Muscle cramping and or fasciculation is an indication of overuse of polio muscles. And if you tuned in the last night's session, you would have heard me talk about the relationship of post-polio syndrome and restless leg syndrome as well. So we certainly have a complex presentation of pain to be expected. We certainly do that. So I affect that and improve it from within our scope of practice. Last night we also talked about medications, and polio survivors certainly respond well to medications that others do. There can be a limit though, given the intensity that some of the pain they experience. So moving on now to in which case you should think about those conservative measures and referring them on to other disciplines who may have different strategies. Even thinking about just occupational therapy, just changing a lifestyle and changing the amount of time somebody is on their feet can reduce leg pain. Reducing the way that someone does their dressing and personal hygiene can reduce strain on different joints. That strain pain that may be accumulative over the day can be reduced by modifications. An orthotist, just by improving the fit of a caliper or an AFO or the like, can reduce shifting of joints and reduce the degradation of joint surfaces and make a snug fit for any device that can reduce erroneous movement that can also help reduce pain. So think about how you can influence pain from within the scope of your discipline. So on to falling now. With falling and subsequent injuries, all other functions of a polio survivor can be very easily disrupted. This particular study, Bickerstaff, Berlin, and Nollet from 2010 looked at the circumstances and consequences of falls in polio survivors. They found that polio survivors fall 4 times as much as matched community adults. Most polio survivors had a fall injury in the year leading up to the study. And usually these falls will happen in the afternoon, during walking, and in a familiar environment. And think back to the profile we just described with regard to a weakness, fatigue. Both of those tended to come on in the afternoon, so we can certainly look at those as factors in falls. Now, when it comes to falls, we need to appreciate those intrinsic variables of the person, the extrinsic environmental variables, and then also that U-shaped inverted U-curve relationship between level of mobility and activity and fall risk. Essentially, with falls, we need to get to the bottom of why is somebody falling. We likely need to enact some kind of change. One of the big things we want to avoid are hip fractures. Fractures were studied by Gupta in 2016. This was a publication in Orthopedic Journal in India, I believe. And Gupta reported increased incidence of hip fractures in polio survivors, and also increased difficulty in reducing and fixating those fractures. Think also back to our second session when we talked about the rate of osteoporosis in this population. And also there were limited options in how to stabilize the fracture due to anatomy, paralysis, and fractures in the area. So we see someone having a lot of falls, we need to have change. And we need to address mobility and the risks we talked about, but we need change. And having somebody change their habits of a lifetime can be particularly challenging. And so I'm going to read a quote from Dr. Laura Halstead, who is from the US, specialist in this polio syndrome, and was actually at the forefront of writing about studying post-polio back in the 80s. And in an interview or in an article that was published in the US, he was followed by the journalist through a course of his day's work, and he, as a polio survivor himself, treating a patient, and he said this statement, which is exceptionally insightful when it comes to polio survivors and getting them to look at change. And he said, "What I want to do is to be able to make any modification that you are interested in that would help you have a more comfortable, enjoyable life." And you can see there's a lot of wisdom here that he's projecting that this is what I want to do as the expert and as the physician. What I want to do is be able to make any modification that you are interested in. So presenting options and timelines of making modifications is certainly helpful. That would help you have a more comfortable, enjoyable life. So tying back this change to better function, more comfortable quality of life. So a very important example of how we can phrase the oncoming change that somebody may have to undergo to improve their safety and their longevity of life. So aspects of assessment. Just remember that your idea of function is very different to that of a polio survivor. And I'm going to give you an example in a moment. But we need to remember not to make assumptions in our assessment, to use open-ended questions rather than closed-ended questions, and to follow any hint of a lead that there may be something that could be investigated or questioned further with regarding function. By open-ended questions, show me how you do that, explain that in more detail. What does that really look like? If someone saw you doing it, what would their impression be of how you perform that task? Because we need to know what risks they inherently have. And they may have spent decades doing something a particular way with a particular favorite device, but we need to know, okay, is that still safe? Repetition and familiarity certainly make scenarios safer, but are they still safe, and would you project that they will continue to be safe using that particular strategy? So that risk analysis during your assessment. So with open-ended questions, if we look at falls, near falls history and balance, ADLs, independence, it's a great place to open the conversation, open the assessment. Really leads down a lot of different avenues of function. We're going to take grocery shopping as a function, and we could easily ask a polio survivor, do you do your shopping independently? Yes. Do you drive to the grocery store? Yes. Do you select all the groceries yourself? Yes. Now, if we didn't delve in a little further, we may just skip over that as being normal, not needing assistance, doing just fine. But if we say, well, how long does it take you to get to the grocery store? So, well, I live 10-minute drive away, but it takes me 10 minutes to get into my vehicle. And I get there and it takes me about 10 minutes to get out of my vehicle and organize with my devices to get into the grocery store. And then I'm already feeling fatigue set in. So I know I've only got about another half hour to get through the grocery store. So I actually come back and do a second set of grocery shopping later in the week. So I do this twice a week because I can't do it all at once. And I make an S shape through the store. If I miss something, I don't go back because I have to keep moving and pick up what I can. I can get a store assistant to grab it for me. Otherwise, I just pick it up next time. I can't use the self-checkout because I need a little bit of assistance with the heavier items, so I always have to go through the regular attended checkout. It takes me some time with the increased load to get back to my car and to unload this, and with the twisting and turning, I always feel unsteady moving things from the trolley, shopping cart, to my vehicle. Now you can see that is a very different presentation. Independent, yes. Drove there and back, yes. Did the grocery shopping, yes. But a different level of what it actually looks like. So keep that in mind when you are assessing your polio survivors. And also keep in mind at what point does fatigue, weakness, pain, and imbalance interrupt that particular function. The orange bar at the bottom of this screen points out we also need to keep in mind in our assessment what level of care and access to resources does this survivor have. Do they have support through the NDIS? Is it through aged care? When was the most recent assessment? Was that assessment as revealing as the example I just gave? Or did the polio survivor kind of brush off some items because they didn't want to change, yet they could certainly benefit from assistance? So be sure to delve into all aspects in your assessment. Polio survivor management. This is a slide that pairs quite well with the one from the medical information yesterday, which was towards the end of that session as well. That one was a blue slide, and on the left of that slide there were the words understand, determine, expect, educate, and refer. So go back to the previous session, you'll be able to find that slide. list on the left-hand side of this slide should be fairly familiar to you. We covered these across the course of the webinar, so I won't go much into those, but when managing, we need to keep all these factors in mind. We don't expect one health discipline to be able to solve all the problems of the polio survivor, and this is why a multidisciplinary approach is useful, and also why the clinics, the polio clinics, of which there are 6 in Australia, those locations are on our website, why a polio survivor may be sent to a clinic for a very close look at their condition. And often that can be when there's a suspicion for a need for post-polio syndrome diagnosis. So refer out to other specialists or to other allied health practitioners if you see something that you've attempted to treat, but you don't have the scope of practice necessary or the tools to take it further or try a different angle. Send them on. Most polio survivors would appreciate a healthcare provider who said, look, I've reached the limit of what I can provide, but I do know where you could go, or a person who could assist you, who could address this from a different angle. They're certainly willing to try things and to give things a chance if it is going to help them maintain that level of function and not cause a worsening, as I mentioned at the start. So appreciate the constraints of their particular profile and condition. Work out what you have to work with and the flexibility of the body that you're working with. And every polio survivor is a different case. Work with modest goals. Don't aim for a 5 out of 5 muscle grading if they've never been a 5 in that muscle group. Be careful with your language and phrasing. While it's great to be enthusiastic and positive and optimistic, don't set or don't say things that may come across as insensitive to a level of ability in your dealings with polio survivors. So this is a quote by Dr. Marion Westbrook. She was out of the University of Sydney back in the 90s. I believe she's a polio survivor, and she did research and did a survey, which some of the aspects of her survey influenced the survey we did this year. Interestingly, in her survey, she identified a lot of those same barriers that I quoted to you at the very start of this session. Now, you can certainly learn a lot from treating polio survivors, but you can learn a lot just from talking to them and get a good understanding of how someone lives with disability, who manages and contributes to their society and communities, but also keep in context that they are of one disability group and there are many disability groups. Some of the concepts we've covered in this series are certainly useful, and looking at those other disability groups as they age, because they can be prone to the same conditions, particularly overuse and dysfunctional movements, and need for assistive device changes over time. So some of those concepts are certainly transferable. I'd encourage you to continue learning on the condition of the late effects of polio and post-polio syndrome. Polio Australia website has plenty of resources that are freely downloadable, you can watch. We also have our clinical manual, Managing Muscles and Mobility, available on the purchase through the website. We have one last slide here that I'm going to bring up, and that is 2 more photos from our photo archive. These are 2 of my favorite photos from our archive. We can see the left side is healthcare providers, the isolation from family during the polio epidemics when a child went into hospital was very distinct. Some survivors report not seeing their family for weeks at a time, some for months, which is quite an extended period for a child to be away and to be dealing with rehabilitation. On the right-hand side, on the left-hand side, we can see that there was kind of a surrogate role for these healthcare practitioners, that they had to take on a little bit of the parenting aspects with having so many children, with the parents being unavailable due to the epidemic, the risks associated. But on the right-hand side, we can see 2 polio survivors who, I don't think they're smiling for the camera. I think they're just enjoying what they're doing, which is participating. It looks like a foot race. Yes, they're using their crutches and they have bracing, but they're still out there giving it a go. In the background, if you look closely, you can see that the spectators are also have bracing and crutches. And so there's a little bit of a community camaraderie sense we can derive from this picture. We see the little boy on the right-hand side leaning into the tape to win the race. So the polio epidemic certainly changed many aspects of modern medicine, and enabled patients who were very vulnerable as children to end up leading very full lives thanks to the interventions of healthcare practitioners. Now, you can make a difference to the current vulnerabilities of these very same people, these very same patients, but just at the very other end of their lifespan. So that is something to keep in mind in terms of perspective on your ability to influence somebody's quality of life and health and function. I certainly recommend you reach out to your local state organisations, Polio Western Australia, and for others listening around Australia, each state has a state org, except Northern Territory, which partners with South Australia. Questions you can always shoot to me via email. The email listed, just bring it up for you. Just on this side, the email here or through Polio Australia, you can call the office line and get in contact with us. We have a clinical advisory group who, when we can't answer questions, we can always shuffle these questions on to someone who's an expert in a particular field, and they're an excellent resource to have. We're very grateful for them being a part of our clinical advisory group. But those difficult questions, sometimes survivors pose some fascinating questions that I have no hope of answering, but I know that if I kind of shoot it out to our clinical advisory group, we can get a response from one of them at least that can give us some insights that we can bounce back to a survivor. But the same applies for our healthcare practitioners in Australia. Shoot us a question if you need something answered, or if you need some advice on a particular presentation you have. You can find out via that mode. We also have a professional health registry, which has a list of healthcare professionals who have trained with us in the clinical practice workshops. Some of those people have elected to give us their details so that when somebody, whether it's a health practitioner, wants to refer to somebody in their local area, or a survivor is looking for somebody who is knowledgeable on their conditions, we can look at that registry. Anyone can search it online and basically type in your area and see what comes up, or the region and see what comes up, and then that gives you an idea of who I can go to close by. So for the final slide here, what will happen with this series? We're certainly going to keep it in our Facebook, Polio Australia's Facebook videos playlist page. We'll look to shift it to our YouTube channel as well. Our learning reflection form we're going to keep online for the next a year or so at least, so that when you're going through these, you can bounce to and from that. Really connects the different webinars together to make it a series. So that's why we utilize that. Thinking back to the screenshot question that I went over at the start, now's a good time to go back through all those screenshots you may have taken and work out hey, which ones am I feel really confident with, that I've gathered enough information and learned about these conditions that those early screenshots not necessarily need to be kept anymore. So all the best. We hope your next encounter with a polio survivor is filled with confidence and empowerment in both of you. And we look forward to meeting you out there when we resume our clinical practice workshops moving around Australia. If you have any questions about those, you can email our office, email me as well. I'm the person who delivers those. We go all across Australia and address health professionals in their education. Great evening.